I'm currently in Brussels, hence a different backdrop you see right now to usual. This is the Sunday paper roundup where I read the paper so you don't have to, and the February issue of the Journal of Isocos has just dropped. Today's paper looks at something every ACL surgeon and every physio treating ACL patients worries about: loss of motion after ACL reconstruction. This was a systematic review and meta-analysis of 48 studies, over 400,000 patients. They specifically looked at patients who required a second operation for stiffness, arthrofibrosis, or a cyclops lesion. Not just mild stiffness, not just a few degrees short, but patients needing manipulation under anesthesia or surgery to remove scar tissue and free up adhesions. What did they find? The pool incidence of loss of motion requiring surgery was 4%. Importantly, in the 90s, the rate was around 10%. Since 2000, it's fallen to around 3 to 4%. That's a major shift. Why has it dropped? Likely because of early mobilization, better prehab, more anatomical tunnel placement, less prolonged immobilization, and more structured rehabilitation. In other words, both surgical technique and rehabilitation philosophy evolved. Key risk factors most consistently reported were earlier surgery in the first few weeks after injury, being female, a concomitant meniscus repair, a pre-op range of motion deficit, and delayed progression in range of motion after surgery. Let's unpack that. Acute surgery operating in the hot inflammatory phase likely increases the fibrosis, scarring. Pain, swelling, effusion, and limited pre-op extension are all major red flags. This reinforces something important: get the knee quiet before you operate. Also, meniscus repair delays early range of motion progression in many protocols, and that delay is associated, it appears, with higher stiffness risk. This is not an argument against repair. As I always say, save the meniscus, save the world, but it is an argument for precise rehab. 9 studies identified being female as a risk factor for stiffness. The authors speculate on immunological and inflammatory differences, but this is association, not causation, so be careful with interpretation. Now let's do critical analysis. Let's be honest, the paper has strengths and limitations. Strengths: massive sample size, clear Prisma methodology, subgroup by era, and sensitivity analysis using randomized controlled trials. But the limitations: huge heterogeneity. Studies were very different from each other, different definitions of stiffness, different rehab protocols, different eras. So the 4% is a strong overall signal, but not a perfectly uniform number across all settings. There were variable definitions of stiffness. Many of the largest studies identified stiffness using billing codes for manipulation or lysis of adhesions, so this 4% reflects patients who actually went to surgery, not everyone who progressed range of motion problems. Most risk factor data was observational. Even though they looked only at randomized controlled trials, the incidence stayed at 4%, but many of those trials had reporting limitations, and so this isn't a flawless data set. So we should interpret that with appropriate caution. And importantly, they only analysed loss of motion that required surgery, not all stiffness, so the true functional incidence of meaningful range of motion deficit is likely higher. What does it mean clinically? Well, for surgeons, prioritise full pre-op extension before surgery, avoid operating on angry knees, and be cautious with aggressive early surgery unless clearly indicated for something like a significant meniscus or cartilage injury, and structure rehab carefully after meniscus repair. For physios, early extension is non-negotiable. Monitor the inflammatory load, manage swelling. It's really important that regular attendance at rehab is key, and range of motion progression must be intentional. So what's my verdict? Well, I think you should be aware of it and keep it in mind when you see patients. This is not practice changing. The paper identifies risk factors, but it doesn't define when we should intervene. There's no time-based algorithm, no comparison of early versus late manipulation under anesthesia, and no clear range of motion thresholds to guide escalation. But it gives you a reliable counselling figure of 4%. It gives us practical framework to identify high-risk patients and potentially intervene earlier, and evidence to justify prehab and controlled rehab and not to rush into surgery. And that is really valuable. Stay tuned for more like this. I'll keep breaking down the evidence as it lands.